Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and chapter immunization representative at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of April 26th, and today, as I record this, April 27th, the global tally so far, total cases of COVID-19 is 148,174,562. Unfortunately, 3,126,000 deaths globally. In the United States, we are 32,161,000 total cases from the start of the pandemic, with 573,201 deaths. In terms of total numbers of cases, the United States remains at the top, as I think we all know, but rapidly rising is the country of India, which at last count was 17,636,000 cases, with an incredibly horrific overwhelming of their medical infrastructure, as I'm sure we've all seen with the media releases. In terms of pediatric data, the most recent report from the American Academy of Pediatrics is from April 22nd, so last week. Total cumulative cases for pediatric age range COVID-19, 3,711,000, which is 13.7% of the total number of cases in the United States. That comes out to a caseload of 4,931 per 100,000 total cases. In Arizona specifically, our cumulative case count is 138,396 cases. That is 16.2% of our total numbers of cases, and our rate comes out to 7,527 per 100,000. We are holding steady at 29 pediatric deaths related to COVID-19, and Texas, again, is the only one on top with 51 total deaths. So again, some great questions coming to us for this week. Almost all of these have to do with vaccine status, and especially the recent hoopla involving the Johnson & Johnson vaccine. Next podcast, however, we are hoping to answer questions created by the board from the chapter, the Arizona chapter of the AAP, looking at how vaccine interventions and COVID-19 management can affect practice management, both in terms of quarantining, isolation, return to work, etc. So you can anticipate some questions which I hope will inform many of us who are managing our own practices and our own case control efforts. So we'll start this week's questions, however, with one regarding specifically the Johnson & Johnson vaccine. And the questioner is asking when and if the J&J vaccine is allowed to be reintroduced. And as it turns out, that was just accomplished several days ago. When or what, I should say, would the restrictions potentially be on individuals? And specifically, might there be a restriction of that single shot Johnson & Johnson vaccine to a certain age, or to restrict it to women of a younger age? So as it turns out, the CDC anticipated that question, thankfully, and has just released, as of today, the 27th of April, a response to that. So the Advisory Committee on Immunization Practices, ACIP, met extensively after initially issuing the hold on April 13th for use of the Johnson & Johnson vaccine, and it has reviewed all the data, looked at the rate and the case attack of the concern for clotting, and then as of April 23rd concluded overall that the benefits of the Johnson & Johnson vaccination, or the Janssen pharmaceutical, that's that subsidiary making the vaccine, that the benefits of that vaccine far exceeded the risk of a clotting disorder. And specifically, what are we looking at? What are the numbers? So as it turns out, since the initial emergency use authorization of the Johnson & Johnson vaccine, there have been almost 8 million total doses administered in the United States of that vaccine. However, since the start of that EUA, Emergency Use Authorization, the Vaccine Adverse Event Reporting System, the VAERS, has received reports of 15 cases of thrombosis with thrombocytopenia syndrome, or TTS. This is very similar, perhaps identical to heparin-induced thrombocytopenia, except that no heparin is involved. So in these 15 cases, all were vaccine recipients. None had received heparin. None had a pre-existing known coagulopathic disorder diagnosed, and yet all experienced this TTS. There were 13 of those 15 TTS cases which occurred in women ages 18 through 49 years, and then the other 2 were in women aged greater than 50 years. So all 15 cases were in women. If you then look at the specific number of vaccine doses administered to women in those age ranges, then we get to an incidence of 7 cases per million Johnson & Johnson vaccine doses for women ages 18 through 49, and 0.9 cases of TTS per million vaccines delivered to women older than age 50. So again, these are very low attack rates. And when you then look specifically at the individuals who received the vaccine and then had the TTS, there were 7 of the 15 who had obesity as a comorbidity, 2 of the 15 who had been taking an oral contraceptive, which, as we know, increases risk of thrombotic disorders. There were 2 who had hypothyroidism, 2 who had hypertension, but very importantly, none of the 15 women, including the 13 in the age range of 18 to 49, none of the women were pregnant or had recently delivered a baby in the preceding 12 weeks. So I say that because that is many times the population that we're most concerned about. Recent mothers or mothers-to-be, and thus we as pediatricians might be dealing with a baby born to a mother with TTS and all the possible complications that exist there. In terms of follow-up, all 15 of the reported TTS patients were hospitalized, 12 of whom were initially hospitalized in an intensive care unit. 3 patients very unfortunately died of complications with the TTS. As of the time of the report, today, April 27th, 4 of the 15 remained in an ICU, 3 were hospitalized but had been transferred out of the ICU, and 5 had been discharged home. So when you look at those data, and this is a very strong microscope drill down into those 15 cases, the attack rate and the risk of the TTS, even when you control for associated comorbidities, is quite low compared to the excellent return on investment or risk versus benefit analysis, whichever you choose to follow, in terms of the Johnson & Johnson vaccine itself. Especially when you look at a single vaccine which has good efficacy and recently demonstrated efficacy against even the mutant variants which are circulating in this country now. And especially when you look at those age ranges of women, the number of cases of COVID-19 prevented in relation to a single case of TTS is huge. So that there is huge benefit. I can absolutely understand the ACIP's finding for this. So the official recommendation then is that the Johnson & Johnson vaccine be opened up to be administered to all ages 18 and up, with, however, a special notice that women between ages 18 to 49 should be made aware of a very, very low risk, a rare risk, of developing clotting events due to TTS. It's not even a black box warning at this point in time, but just simply something which is being provided on the vaccine information sheets, the VISs, which we're all encouraged to provide. So there you go. It's a long-winded answer to the question, which is, yes, the Johnson & Johnson vaccine has been reapproved to be delivered to all age ranges 18 and up, but with the caveat that an additional warning is on the labels or on the VIS, the sheets, for those women ages 18 through 49. But no one is restricted from receiving it. Okay, so speaking of who gets vaccine, obviously lots of questions about the eventual and hopefully soon or impending pediatric indication for vaccines. As has been discussed before in this podcast, the Pfizer messenger RNA vaccine has emergency use authorization for ages 16 and up. Moderna vaccine, Johnson & Johnson, eventually AstraZeneca, if they get licensure, are all approved for ages 18 and up. However, Pfizer has already collected and submitted data, safety and efficacy of its vaccine in children ages 12 years old and up. And Moderna and Johnson & Johnson are currently completing their study trials of that same age range. So one can anticipate, in fact, I would say it's hopefully likely that we'll be hearing an indication for ages 12 and up for the Pfizer messenger RNA vaccine for 12 years old and up in the very near future. I imagine it would have occurred sooner, except that the ACIP and the FDA and the CDC were very focused on the concerning events with the TTS and the Johnson & Johnson vaccine. So hopefully it's back to business as usual, looking at the pediatric data, and I anticipate at least one vaccine product in the near future and 3 vaccine products in the next several weeks to months will have a 12 years of age and up indication. What about then the other kids? And as again has been discussed before in this podcast, Moderna is currently studying ages 6 months of age up through 12 years of age. And the recruitment for those pediatric trials is, shall we say, robust. In fact, just anecdotally, friends of mine who have attempted to get their children enrolled in the Moderna trial, which is cited in Phoenix, have been told that the current recruitment is filled and to call back later. So hopefully that means just ongoing robust recruitment. And very importantly, so ongoing safety and efficacy data, which with I think luck and also just ongoing scientific focus will give us answers and potentially FDA data by this summer. So it is not a stretch to say that we may actually have a pediatric indication for at least one and perhaps several vaccine products by the time the next school year starts. So we're talking August of 21. Fingers crossed that actually is so. Next questions then have to do with especially global travel. And perhaps many of us have seen that the European Union has announced that vaccinated Americans can start their travel plans, travel to countries in the EU by this summer. Do we expect other countries to follow suit? Yes, I think so. Certainly the travel industry, the hospitality industry has been hurting horribly around the world, and having a collection of countries within the European Union to take the stage, set the precedent, is going to be encouraging to many other parts of the world. Still unanswered, however, will be what, if any, requirements will be mandated for a traveler to actually depart United States and land someplace else. I'm sure we've all seen the ongoing raging debate about the so-called vaccine passport and the potential impact on freedoms as that might have. However, in terms of traveling, we know that we have to have a valid U.S. passport, and it's not unreasonable for a receiving country to expect the same with some degree of proof of COVID-19, either disease and immunity or vaccine and immunity. So as I say this, I have not seen any specific maneuvering or political language or anything else to suggest that actually will be the case, only that is being considered. And it does make sense. Certainly it makes sense in terms of not importing additional disease or a different collection of variants of the mutant viruses into another country. But it also makes sense from a matter of personal safety, of course. So I think we can anticipate opening up of global travel unless or if a third or fourth or fifth surge does occur. And I imagine that there will be some set of requirements for proof of immunity. Perhaps an immunity passport is the better term to use rather than vaccine passport, which I certainly agree can be a polarizing and challenging concept for those who are vaccine hesitant. So stay tuned for that as well. I imagine we'll be hearing a lot more, perhaps even later this week and certainly over the next several weeks. Next set of questions then have to do with the sort of shifting target for herd immunity. What's contributing to that? What is the current estimate? How since we know the relative efficacy of the vaccines, although I would argue that's a changing target as well, do we have a sense for what percentage of the population needs to be immunized to reach herd immunity? So important to this question is the concept that wild type infection, meaning having had actual COVID-19, may not provide the lasting immunity which we're looking for to achieve protective herd immunity. I say that just based on some data, pilot studies, and case reports that have looked at individuals with mild or asymptomatic COVID-19, the actual disease, and found to lose a detectable immunoglobulin to SARS-CoV-2 within 3 to 4 months. Now, that does not necessarily mean they're at risk for getting secondary or recurrent infection, although even that has been proven by multiple case reports. It simply means that it's hard to detect their antibodies. The concept of neutralizing antibodies, which are going to be a different detection method potentially than the quantifiable immunoglobulin G, and the potential of having immortalized T and B lymphocyte cell lines ready to respond to a rechallenge, all that remains to be completely fleshed out. However, it does appear clear, just given the fact that recurrent infections have occurred in previously infected individuals with COVID-19, that wild-type disease immunity may not be as protective as we would like it to be. On the other hand, vaccine-associated immunity is incredibly robust to a specific target, i.e. the spike protein. That target is incredibly important because it directly affects the virus's ability to cause disease. So hence the recommendation by CDC that even those COVID-19 survivors are encouraged to get vaccine to further boost, and if anything, to create monster immunity against the spike protein so that they are well and truly long-term protected. I'm sharing this sort of sideline thought process because the factors involved with wild type versus vaccine associated immunity are also going to affect what the target number is for herd immunity. The other part of the story, then, this is the part two, is that the increasing impact of the virus mutants or the variants also has to be accounted for. We know that the vaccines currently licensed or being used in the United States via emergency authorization are still effective against the variants, although with up to 6 to 10-fold decreased efficacy. Simply means that against wild type virus, the vaccines created like robust immunity, like 100 times necessary. So a 6-fold decrease, while not ideal, certainly is not a huge cause for concern in terms of disallowing the ability to respond to a mutant virus. So all that said, however, the percentage of people with successful, efficacious immunity may be a little bit lower when you compare it to response to the virus mutants. And therefore, the number of people or percentage of people with immunity needs to be increased to create that herd immunity. So the answer to the question, what is the current target for herd immunity? It had been 70-75%. Estimates are now getting closer to 85%. So that's a significant jump, especially when you take into account the vaccine initiatives and the vaccine rates that we're achieving in Arizona and elsewhere, not just in the country, but elsewhere globally, are starting to plateau. We've reached the most easily accessible, certainly the highest risk people, and now we're encountering exactly those vaccine hesitant people that we as pediatricians are quite familiar with and quite experienced with, by the way, in terms of having those vaccine conversations. So 85%, I think, is the current target, and that seems to be a long ways off, to just put it to be quite blunt. Not hopeless at all. I just simply put that as a target of opportunity for us to navigate going forward. And then the last question that I have for you today is, are children experiencing long COVID-19 like symptoms like adults are? And yes, unfortunately, they certainly are. I've actually seen several just in the past week or so in my clinic. And just like the adults, pediatric long COVID syndrome, which is one of the terms being used, involves children presenting with fatigue, significant fatigue, exercise intolerance, decreased activity, headaches, malaise, myalgias, and especially the anosmia and parosmia. So loss of sense of smell and disordered sense of smell and therefore taste. All these have been recorded. And then in rare instances, there also have been some neurologic complications, including Bell's palsies, cranial nerve palsies, certainly some evidence of encephalopathy, encephalitis. So in terms of the first major category, those being the fatigue, exercise intolerance patients, and also those children suffering from the equivalent of the COVID-19 foggy brain, the encephalopathic changes. These patients are very similar to what one might encounter, certainly in an athlete who encountered, I don't know, infectious mono, for example, or some other life-affecting or life-limiting disease process, who then has become very rapidly deconditioned. So as with those athletes, so too with long COVID-19 pediatric patients, the answer is to exercise recondition, starting slowly, just like most of us would do with a patient suffering from chronic fatigue syndrome. My practical personal experience has mostly been with chronic fatigue in children suffering from infectious mono, from EBV, or from valley fever, cocci. And the approach has always been to set a 1 week by 1 week increased goal chart. So you're stuck on the couch. Okay, so this week you're going to be getting up and walking around the house. Just getting to the end of the house to get a glass of water. Just get off the couch. Next week, you're going to walk outside. Week after that, walk around the block. Week after that, walk around 2 blocks. And you get the picture. The key, though, is to engage the patient, as I think many of us have done, in their own recovery. So let's create the exercise increase chart together. What's achievable? What's a stretch goal? Perhaps even like, red, yellow, green in terms of our goal setting. That's for the exercise intolerance, and our colleagues in sports medicine are already tooling up to help us with that. Regarding the post-COVID or the long COVID foggy brain, the encephalopathy, the cognitive dissonance is perhaps the best term to use to describe this. Exactly like our children and our adolescents with traumatic brain injury. So there are going to be, or there is currently an increased need for exercises and cognitive exercises to address that. Here we also can turn to our colleagues specializing in traumatic brain injury. So whether those are the behavior developmental specialists, the sports medicine specialists, you name it, but I think we have a lot to learn from individuals who have been working in those regards. Also, and perhaps the most common finding which I've encountered in the long COVID survivors and kids, in addition to fatigue, has been the alterations in sense of smell. And very commonly, it's not total loss of smell, but just that things which used to smell pleasant, or foods which the child used to really enjoy, now smell horrible. Best case in point, it was a young lady I had in the office the other day who used to love eggs and dairy products, and now can't even abide the thought of those because they smell like rancid fish. I'm paraphrasing her description for that. So boy, how do we address that? And this is something our adult colleagues have been dealing with as well. The first part, if they're having perception of smell, is, again, just based on very anecdotal experience, put on the nose plugs, block off the sense of smell, so at least there isn't that as a negative associative factor. And then, as with those who have lost a sense of smell, begin olfactory retraining. Get a scent kit, and those are available. So identifiable smells that the child may remember. Okay, so this one is peppermint. Remember having peppermint. Okay, waft the scent oil under the nose while having the child try to remember what peppermint used to smell like. So it's a slow, steady process. I don't have personal experience using that, but I'm sure that some in our chapter do. And I would love to hear from you if that is so. What have been your personal experiences using this? Has it worked? What are the hurdles, the barriers, the opportunities? So yeah, that's a long way of saying long COVID-19 does exist in pediatric patients, very unfortunately. It is a collection of symptoms and signs that I think many of us are familiar with, especially if we pull in our experiences with children suffering from chronic fatigue syndrome. There are a lot of parallels, and certainly there's a lot of research ongoing right now in many parts of the country to look at physiologic and pathogenicity profiles of these patients and see if we can find or determine additional interventions. So there you go. That's a lot about vaccines and a fair amount about long COVID. Thank you once again for listening to ID Talk. As I mentioned at the start of the podcast, we anticipate having a sort of practice management specific set of questions in the near future. But please do submit questions for future episodes and your input and your thoughts and your experiences to covid@azaap.org. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. Once again, thanks for listening. Thanks for the service that you all are providing. Hang in there, folks. We're continuing to get through this, and we still have some work to do. Thanks a bunch. Bye-bye.